Hello and welcome back to Therapeutics. In this block, we'll talk about hyperlipidemias. I have to say that in clinical practice in the last maybe 2 decades, clinicians have seen a number of updates and guidelines, with some guidelines conflicting with others over the last 2 decades or so. But things have somewhat settled out until about 2020 or so, when there have been a couple of new interventions on the horizon and trying to see where those fit in cardiology. So, as of November 2022, we'll walk through the guidelines for both elevated LDL and elevated triglycerides, particularly in the context of patients with a higher cardiovascular risk. So our objectives are really to go through the treatment options in hyperlipidemias, and these treatment options are not uh, are not limited just to a certain threshold level of LDL or HDL cholesterol or elevated triglycerides alone, but are done in the context of what is the cardiovascular risk profile for the patient in front of us. So, as we talk about hyperlipidemias, let's walk through first some of the considerations we have in a patient who presents with a hyperlipidemia or a risk for hyperlipidemia. One of the things I think that's important to recognize is as you're doing lipid evaluation, if a patient has either an elevated LDL or an elevated triglyceride, you want to see to what degree is there a fixable or a adaptable cause to which we can amend and change things, whether it's medications, whether it's diet, whether there are comorbid conditions or other syndromes that are associated with it, and then how we manage those. So important for us to keep that in mind. The other issue we'll talk of when we speak of comorbidities, probably one of the greatest ones here, is going to be diabetes. And so our management of hyperlipidemias, in particularly patients who have diabetes or are at risk for diabetes, is likely more aggressive based on their 10-year cardiovascular risk profile. So our first line intervention for everyone with a risk for a hyperlipidemia, be this LDL or, we'll talk about in a bit triglycerides too, but for LDL reduction and reducing cardiovascular risk are lifestyle issues. And those are diet and exercise primarily. A diet that might be a lower glycemic index diet with less saturated fat and more exercise. As you will talk about in ClinMed, uh, you should have an appreciation for the role of pathology in elevated LDL levels, elevated HDL levels, which is a good thing, which really pretty much serves as a scavenger for LDL and brings it back to the liver so it can be processed. And also, to some degree, the role of triglyceride risks, primarily in pancreatitis, but also in cardiovascular disease, as an added risk element in cardiovascular risk profiles. For all of these patients, you're looking at diet, exercise, weight loss, smoking cessation, glycemic management, blood pressure management, and lipid management as part of all of their cardiovascular risk profile that we talk about time and again. So we don't look at hyperlipidemias alone, but in the context of cardiovascular risk primarily. When you've exhausted or have done the most you can expect a patient to achieve, and they still haven't met whatever goals they are, or their risks are still, assessed or estimated at being high for their cardiovascular risk, then particularly for elevated LDL cholesterol, we look then at adding statins as first lines for virtually everyone. Statins have great data. They are relatively safe modalities to use. There are some adverse effects, but we really want to evaluate that the benefit and the risk assessment is thoroughly examined in a patient before we write them off as someone who is statin intolerant. So all of these sort of other factors are important. And I think one of the things you'll expect or find is with that statins do a great job at lowering LDL. They don't do that great of a job at elevating HDL. The best thing that's going to elevate HDL for a patient is exercise. Diet's going to make a difference too. Diet's going to have influences not only in saturated fat and fat content, but is also going to impact triglyceride levels for a lot of patients. What you have to recognize is that, though, despite the fact that a patient may do really a lot of hard work and are really pretty adherent to an excellent diet and exercise regimen, they may have genetic predispositions for hyperlipidemias as well. And those patients often will be seen by a lipid specialist to evaluate their lipid risks and may not benefit alone from a statin and may need add-on therapy, and we'll talk about that. But the bottom line, and we're going to spend a fair amount of time here on statins because statins are so good. The data for statins in reducing cardiovascular risk is it has been around for about 30 years or so, and it's robust data. Safety data is also good with statins, and so they are really first line. So let's go to the statins. They work by competitively inhibiting the HMG-CoA reductase, which is an enzyme that is involved in cholesterol synthesis. Lovastatin is one such drug. It was sort of the landmark drug, the first drug on the market. We don't really use lovastatin anymore, but you may still see lovastatin sort of around occasionally on, for example, a $4 drug list somewhere. These drugs work well at increasing HDL cholesterol levels a little bit, but they really have their claim to fame in reducing LDL and VLDL cholesterol. They also have likely a significant anti-inflammatory activity that beyond their ability to lower cholesterol, their anti-inflammatory component may reduce the risk for an atherosclerotic plaque rupturing and triggering a clot. And so statins, their benefits go probably beyond just the cholesterol lowering level. So important to think about that. Now, all that said, there are some issues with statins or HMG-CoA reductase inhibitors. The biggest one are women of childbearing age where these drugs are teratogenic. Keep in mind that these drugs affect the synthesis of cholesterol. Cholesterol is a necessary ingredient in making new membranes, and I think in fetal development, cholesterol synthesis is key in fetal development. And so these drugs are avoided in women who could become pregnant. So important to recognize all of these sort of variables and assessing teratogenicity risk for every patient who gets it. We often forget that because statins are just so widespread in their use, but absolutely need to confirm that before you move forward. The other concerns are usually big concerns for patients, but in fact, many times aren't seen to the degree that patients have a fear of them. One is the muscle ache, pain, and rhabdomyolysis risk. That happens. It clearly does happen, and it's been documented that it does. That said, many times we find patients who start on statin therapy and then a week later, they're in your office complaining, I've got muscle aches. You have to work them up and say, where are the muscle aches? Is the pattern consistent with the muscle breakdown that could be seen with statins, or is it related to the fact that this patient got a little religion and is going to the gym and using muscles they haven't used before? Are there interactions with the statins that elevate the levels of the statin that you didn't account for? So important, we'll talk a little bit later about working them up, that we don't automatically say that a muscle ache means you stop a statin, because statins are so good. We want to make sure that that the statin could be used if it's safe to do it. Either that statin at a lower dose or a different statin. And so it is very common in this day and age that if someone has a history of muscle aches with a statin, we work them up and consider trying them on a different dose of that statin or an alternate dose or an alternate drug at as a secondary trial before we label them as statin intolerant. We also worry about hepatotoxicity. Not all that serious or complicated in most patients, doesn't happen very much at all, but one of those things that we will look at. Most often it's reversible when you stop the statin. So the big contraindications for statins are pregnancy. We also don't give them in women who are breastfeeding. We look at active liver disease as being an issue with statins, hypersensitivity in folks who are, demonstrated to have had a documented statin intolerance for which they may tolerate a different statin. And so you want to make sure that's the case. For the most part, the only two statins you're ever going to see used in this day and age are atorvastatin or rosuvastatin. They're both generically available now. They are relatively inexpensive, and they are probably the most effective in the dosage ranges we use and the best tolerated of them. So you pay attention to some of the drug interactions that are involved in these two agents. You may pick one over another based on that, but it's quite infrequent now that we would start somebody on one of these other statins listed here. You will still see patients on some of these older statins, but in this day and age, the advantage of atorvastatin or rosuvastatin is that when we pick a dose, we know that we could pick a low dose, a moderate dose, or a high dose of these two drugs, and with the same very drug but a different dosage, we can achieve varying levels of intensity of the statin. Important for us to recognize statins have been around for a long time. Pravastatin, one of the first agents used, and that's been the data from nearly 2 decades ago, looked at 15 years of data and found that the data for cardiovascular benefit was clear with statins and the risk was pretty minimal. And so important for us to recognize that statins have a long track record. Sometimes patients may be on a natural product called red yeast rice, which also has a natural statin in it. So that could be an alternative for a patient who is absolutely not wanting to go with a existing pharmaceutically graded statin. But in practice, we would not recommend doing that except for the patient who absolutely won't take any statin except red yeast rice. So you won't likely see that very often at all. Important when you think of statins to look at statin potency, because some of the older guidelines and guidelines we still use will look at what potency of statin dosing, a high intensity dosing regimen, a moderate intensity or low intensity statin regimen, and then based on the indication, go with the agents that'll achieve that. And the only two agents that will achieve a high intensity statin regimen because of their potency and efficacy and safety are atorvastatin and rosuvastatin. And so in practice, we look at lower dose of atorvastatin or for moderate intensity coverage, or very low dose of rosuvastatin, or the higher end of the ranges of both drugs for high intensity statin dosing. This is a summary slide of the 2018 guidelines that are pretty much still utilized. We just have a couple of other options here as well. Let me go through this slide in a couple of minutes with the statins. So for individuals who have existing atherosclerotic cardiovascular disease, these are folks who maybe have had an MI already, or they have angina or other issues. We stratify these individuals, but every one of them, for the most part, is going to be on a high intensity statin. The only cohort that maybe we question about high versus moderate intensity statin are patients over the age of 70 or 75, for which there is a little less data for. Plus, keep in mind that we are giving a drug that has a benefit 10, 20, 30 years in the future. And so as individuals get to become older, frailer, elderly patients, the benefit of that drug diminishes a bit because their lifespan is likely to be shorter. But that said, many patients who are over the age of 75 still are on statins, and probably appropriately so, particularly if they can tolerate them well. What you'll see on this slide, we'll talk about in a bit, in the last two columns to the right, are after statins. If you don't achieve adequate cholesterol management, which we usually look at an LDL cholesterol above 70 for folks with atherosclerotic disease, or above 100 if they have other risk factors but not existing uh, cardiovascular disease like an MI history or something. Those individuals are candidates for Zetia or for one of the other alternatives. We'll walk about through those in a bit. But I want you to focus first on statins because virtually everybody who is a candidate for LDL lowering after diet and exercise is going to be a candidate for statins. Okay. So there is the first data for individuals who have existing atherosclerotic disease. The next are patients who have significant elevated cholesterol. These individuals often may have some historical family history, genetic predisposition, some other variable. These individuals are also candidates for high intensity statin dosing. And so often these individuals may or may not be seen also by a lipid specialist. The third cohort are patients with diabetes. And most of the data for using statins in diabetes are primarily in the patients from the age of 40 to 75 years of age, where we look at their 10-year risk profile, cardiovascular risk profile, and look at either being on a moderate intensity or a high intensity statin. If they can tolerate it, most clinicians recognize that the higher the dose of the statin the patient can tolerate, the better off their risk, the lower their risk factor is likely going to be. There's less data for patients, under the age of 40, but it's still quite common for patients with diabetes that we are looking at managing with statins in that cohort if there are other risk factors, cardiovascular risk factors present with the diabetes. And over the age of 75, again, statins probably still pretty commonly used in patients with diabetes because their cardiovascular risks are higher just from having diabetes. Now, you may have a patient whose A1C is superbly controlled, who doesn't have any other major risk factors, for which you may, elect a lower intensity statin regimen, particularly if it's not tolerated. So you're kind of looking at the patient in front of you. But the guidelines pretty much are all of these individuals in this slide are getting statins. Finally, we look at primary prevention in patients who don't have diabetes or severely elevated cholesterol. And for the most part, we're looking at their 10-year cardiovascular risk profile. And based on those results, looking either at just lifestyle issues alone or considering a moderate or high intensity statin regimen. In what we just saw this summer is a publication of a summary of the guidelines for statin use in primary prevention. And these guidelines are consistent with what you just saw, that for the most part, patients who have cardiovascular risks of a 10-year risk factor greater than 10% or existing atherosclerotic disease, these individuals are good candidates for statin therapy, and most often the higher the risk, the more likely you're going to go with an intense regimen. For patients who are age 40 to 75, that risk factor, again, what we just went through, those individuals would also likely still be on a statin, particularly if their sort of profile of risks or family history or genetics or something else predisposes them to it. This latest update is a little more equivocal on patients over the age of 75 in that there is less data in this cohort. Doesn't mean that it's not appropriate. And I think most clinicians would find a higher risk 77-year-old who otherwise is in reasonable health and could benefit from a statin, particularly if they've already been on a statin, is likely going to continue statin therapy. The other things that are important with statins are to pay attention to drug interactions, because the interactions, particularly those interactions that elevate the level of the statin, can greatly increase the risk for rhabdomyolysis. And so, important to pay attention to drug interactions here. And the issue often is, if you've got to give a short course of a drug that is known to elevate statin levels, there might be a benefit of reducing the statin dose for the window of time of that antibiotic regimen or something else. Okay. But short of that, you really want to pay attention to drug interactions and then carefully monitor for any adverse effects, particularly muscle aches or pains. Here's a table of the kinetics of statins. Not important for you to recognize these really because they're all going to be dosed pretty much. The only two you're going to use are atorvastatin or rosuvastatin, and those are really dosed pretty much once a day. And they're often dosed in the evening, ideally, because the evening is associated with more cholesterol synthesis overnight. And so that's the sort of the magic of dosing statins in the evening. That said, if a patient only takes meds once a day and that happens to be in the morning for them, then so be it. It's better to take 7 out of 7 doses a week in the morning than to take 4 doses out of 7 a week in the evening. Okay, so the incremental benefit of evening versus morning is a little bit, but not enough to warrant them missing a couple of doses a week. Okay. Some of the statins require dose adjustment for renal dysfunction. That's particularly true for rosuvastatin, but for the most part, not. Most of the patients you're going to have on statins aren't going to be in end-stage kidney disease. And then there are sets of guidelines for how to manage patients who have intolerance to statins. There are a number of summary guidelines in this table. I'd encourage you to scan that just for a minute. You might want to stop the slide and just read through it. There are definitions of statin-associated muscle symptoms and how they manifest and maybe the CK levels associated with those and how they're each described based on each guideline. And then here is a sort of a nice checklist of assessing statin-related muscle symptoms in patients, trying to make the determination the degree to which the statin is causing the muscle symptoms that are being presented or not, and the degree to which this patient is a candidate maybe for a rechallenge at a lower dose or a different statin. Many clinicians will likely in primary care, when they see this, might refer the patient to the cardiologist to evaluate the statin intolerability question and have that cardiologist rather than the primary care individual do that. But it certainly is within the realm of someone in primary care to evaluate statin-associated muscle symptoms and consider whether or not a rechallenge might be appropriate. Finally, an intolerance to statin, here are what are sort of considered, a way to think through the degree of muscle severity and who might or might not be a candidate for a rechallenge at a lower dose or with a different statin. Finally, as we think about statins, there's been a lot of questioning and debate about whether CoQ10 with a statin offers benefit or not. The bottom line is it's probably not really been well studied. Here's an old 10-year-old study that was really too small to really be able to answer this question. Okay, very small study. But the data is that CoQ10 probably, in theory, offers a benefit in patients who are on statins, but in practice hasn't really ever been demonstrated. CoQ10 probably won't cause anybody any harm, but CoQ10 supplementation is probably going to cost a patient, $30 a month for CoQ10, and it's another pill to take and it's another pill burden. So if a patient is pretty adamant about wanting CoQ10 supplementation with their statin, sure. If they can afford it, if it's not getting in the way. But if they're starting to have some sense of pill burden, I take too many pills, I want to streamline my pills, CoQ10 is likely going to be one of the ones that are going to pull away. Okay, so you'll see many patients who are on statins in practice, and for whatever reason, statins and the lifestyle things that you have to harp continuously on, the diet, the exercise to get their HDLs up, the weight loss, and then managing diabetes appropriately, all the other things that are real struggles for patients. Statins are the first line for almost anyone. If they're intolerant to statin, we retrial it. What if their cholesterol remains elevated or they're not at goal of where they need to be with statins alone? What do you do then? Or if they're intolerant to statins? Well, this year, just very recently, is a consensus statement on a decision pathway. This was published in October of 2022. The role of non-statin therapies for LDL cholesterol management in patients where you're trying to manage the atherosclerotic cardiovascular risk. So there's a lot of slides here, and I'm going to go through them fairly quickly. It's not expected that, you really need to know statins. There's 2 or 3 drugs on here that I think you need to know, and need to know, some of the drugs that are on the horizon are listed in here, or the interventions here. But most things beyond statins, with 1 or 2 exceptions, is going to require a prior authorization from a, usually a cardiologist or someone else to sort of indicate why they have failed statin alone therapy. So, you'll see that in practice. So many of these non-statin, beyond statins, some of these are within your domain. I'll talk about them as a PA in primary care, but there are others that are pretty much beyond, you're going to send a referral out for. So the nice thing about this set of guidelines is they pretty much supported what was already in place, but they now recognize that we have 2 or 3 or 4 other interventions that we are really still awaiting documentation of the cardiovascular benefit and outcomes for, and clinicians are not quite sure where they fit. And so this set of guidelines, it gets very detailed. And it's not our expectation that you're going to know that. But I think it's important that you have an awareness that these guidelines are evolving and that clinicians beyond statins are trying to figure out what to do with all these new therapies that are coming out. So here's a nice table that summarizes who are at very high risk for a future event. These are the very patients for whom it is likely that you're going to maximize statins if you can. And then beyond the maximizing statins, they may need something else. That's what this set of guidelines is. Once you've sort of maximized statins, what else do you do? Here's a table of risk enhancing factors. These are things that aren't quite as table 1 listed in this document. These are not quite as strong drivers for beyond statin therapy, but they add to it. And so, if you've got someone with really elevated cholesterol and maybe they don't fall into all of table 1 categories, but they have a number of these going on, then that's important for us to sort of consider in practice. Okay. There are strategies to consider here, when to refer to a lipid specialist, when you really want also dietary support and other kind of guidelines, management with the lifestyle issues as well. The next few slides have a fair amount of detail about the non-statin agents that are available. And a couple of them we're going to spend a little more time talking about. The first one is ezetimibe or Zetia. Zetia has been around now for more than a decade and a half. It really works to reduce cholesterol absorption in the small intestine. It works moderately well. We don't see the big improvements in LDL and HDL and triglycerides we see with the statins, but it moves the needle a little bit in the positive direction for patients who maybe don't get to goal with the statin or maybe can't tolerate a full dose statin and the like. Pretty well tolerated therapy for most folks, but some individuals will get some GI distress, some diarrhea. There's been reports of joint pain and sort of other things that are problematic. We don't have data in women who are pregnant. And the cardiovascular outcome data is not nearly as robust as it is with the statins. But ezetimibe is an agent that you will see clinicians go to after they've maximized a statin and haven't got quite to their goal. If you remember this earlier graphic that looked at who were candidates for statins, you've maximized your statin as step one. You might consider Zetia in patients who've had an atherosclerotic disease where their LDL, fasting LDL cholesterol, is above 70, or if they have hypercholesterolemia history or diabetes or something else where their cholesterol's still LDL remains above 100 and or their cardiovascular risk is above 20%. Also, you may consider if patients are intolerant of statins entirely, then Zetia might be a reasonable consideration. The other agents that have been around now for almost a decade are the PCSK9 inhibitors or monoclonal antibodies that affect PCSK, 9, which affects LDL clearance overall in circulating LDL. And these interventions they're expensive. They're typically administered parenterally, periodically every few weeks or so. They have a clear benefit associated with them, but they're expensive and they're really limited to patients who have maximized Zetia and statins and still are at very high risks. These drugs are typically going to require the cardiologist or some other person out above primary care to authorize them and to document the prior auth needed for them because these drugs go into thousands and thousands of dollars a year. The second portion of this slide is also listed here, which goes through some more specifics about where some of these drugs are used and how they're used. These drugs do show up in the 2018-19 guidelines. They are step 3 after statins and Zetia therapy, but they are really limited to pretty high risk patients who didn't get to goal. For moderate risk patients like with diabetes but haven't had an atherosclerotic disease, these drugs really aren't indicated and likely won't be paid for. And these drugs have no role in primary prevention for individuals who haven't already had an MI. The other couple of therapies that are listed here are pretty new on the block here. And these therapies pretty much are not, if I sort of have your eyes scroll down all the way to the bottom of this slide or near the bottom, where they talk about cardiovascular outcome trials are not completed. They're expecting data to begin initially to be published in late 2022. It's already late 2022 as I'm recording this, and they're not there yet. So I think that people are excited about what these may mean, that where they're going to fit in the standards, but we're not there yet. And I think most clinicians are quite hesitant to use a new agent with a newer mechanism where we don't really know in large numbers what the safety issues are. Initially, even with this drug, we've seen issues of tendon rupture and uric acid level elevations, among other things. Upper respiratory tract infection risks may be higher. Patients often will talk about muscle spasms, for which then, if they're already in a statin, or they have back pain or abdominal pain, how do you assess that and what's causing it, as well as maybe elevated liver enzymes. So we don't really know enough about this drug for this to be in practice yet. But expect that within the next 5 years, this will be ironed out. So also, as you look at other options here, are this combination of this drug with Zetia also is a consideration for a subset of patients. But again, the cardiovascular outcome trials, we're still waiting for this data before, and we're looking actually for a greater body of evidence for this data for it to mature before clinicians are ready to say move forward. The other options that are listed here are more strategies of direct inhibitors of PCSK9. And this is, again, another therapy that we're waiting for more cardiovascular trials to come out. So think this is an agent maybe down the line that may make sense, but is not currently a therapeutic option we have now. Here they list the bile acid sequestrants. Bile acid sequestrants have been around for 50 plus years. These agents are non-absorbable GI drugs. They're polymers that bind bile salts, bile acids in the intestines. They will reduce cholesterol absorption a bit. The issue with the bile acid sequestrants are that they will move the needle to improve cholesterol, but they don't really have that much of an improvement that is seen for cholesterol levels. They have to be often dosed multiple times a day. Patients often have a lot of GI distress with them. They don't, for the trouble that they cause and the side effect profile that they have, and the way they bind other drugs in the gut to reduce absorption of a number of drugs, these drugs are often more trouble than they're worth. Clinicians, it's rare that I see clinicians use bile acid sequestrants anymore. They used to be commonly used before the age of statins when that's all we had, but no longer is that a common modality. And you'll see sort of here on, again, there is some reduction in cardiovascular risk, but we don't see a 19% reduction in old trials. That's not the same anywhere close to the statins, and a really difficult drug for many patients to tolerate. The other question we don't know is if they're already on a statin, how much more benefit will a bile acid sequestrant offer? Because most of these studies were done, at least historically, before the availability of statins. So you won't see bile acid sequestrants very much. The other issues you'll see here are agents that might be chosen by a lipid specialist based on family history. I'm not going to go into these at all. You can sort of look through them. Here's more about patients who may be candidates for using one of these other modalities, but again, a lipid specialist. And again, more LDL apheresis, again, a procedure that is pretty much limited to patients for whom everything else has failed and their risk profile is significantly high. Other things that they talk about here in this set of guidelines are clinician-patient discussion issues that come up. I encourage you to scan through this, but cost considerations may be big. Statins are cheap. Almost everything else but statins are not cheap. And so that may be difficult for some patients to be able to financially afford some of these modalities, particularly if either they're not covered by insurance or the copays are large. The remaining next slides here for the next 10 slides, I am not going to go through. These are algorithms from the October 2022 guidelines for the role of anything beyond a statin. Expect that the principles here are pretty much the same, is that you are maximizing diet, exercise, and statins, and then you're layering on that which modality may make sense beyond that. And it's not much different from what we just alluded to, but I'd encourage you to look at these set of guidelines if you wanted a more specific, and at least as of October, November 2022, where these algorithms stand. Expect that they will change as more data happens. Again, here is one of a number of these algorithms. If you're interested, I encourage you to stop and sort of walk through the slides here, but again, not a focus here. Beyond statins, many of these are not going to be things that you in primary care are going to manage. Another set of algorithms, more algorithms, more. They also will define, various family histories for patients who have familial hypercholesterolemia. And most of the time, these are patients for whom they get genetic assessments done. They're usually done by someone in a tertiary care center who does a lot of lipid management specifically. More guidelines, more algorithms, more algorithms, more. Other drugs that have a benefit for LDL, but probably minor and aren't in the guidelines, is a high fiber diet, or high fiber psyllium binds a little bit of cholesterol, not a lot, certainly not enough for somebody who's at high risk. But if they're a candidate for psyllium for bowel prep, there's probably some little bit of benefit that might be achieved here. The issue we'll talk about in the GI block is that psyllium sometimes associated with some hypersensitivity reactions, associated with a lot of gas for patients, so it may be less tolerated compared to other alternatives to psyllium these days. And then garlic in beyond just garlic in a diet, but supplemental garlic has some modest reduction in cholesterol as a natural herbal product. But, you typically don't see a benefit beyond a reduction of 10% or so. We don't really know what the cardiovascular outcomes are. And we often look at a couple of things for patients if they're on garlic, and going into surgical procedure, for example, that can actually affect bleeding risk and platelet function in a surgical procedure. So we usually look to stop garlic before patients are having seen in surgery. It's pretty infrequent I see anyone on garlic anymore. It had its heyday a few years ago, more than a few, but it's pretty rare. The benefit is pretty limited, and you won't see it published in guidelines. Let's shift gears now to patients who have elevated triglyceride levels. When we look at which agents will lower triglycerides, already some of the drugs we've talked about, really two of them, the statins do a modest job at lowering triglycerides, and Zetia does a very modest job at doing that. What we will see used are the omega-3 fatty acids as a first-line regimen, and the fibrates are also considered when omega-3 fatty acids are not quite doing the trick. In mid-2021, there were consensus guidelines for managing hypertriglyceridemias. Again, like the other set of guidelines can look pretty complicated. I'll try to walk through them, and then we'll stress really the two issues are going to be diet management and moderate exercise and glycemic control, lifestyle things. Then we'll look at either omega-3 fatty acids or fibric acid derivatives, and that's really it. Let's walk through these. So here's a table of secondary causes of hypertriglyceridemia, for which a number of conditions will be associated with that, particularly uncontrolled diabetes or elevated glycemic index is a big deal for a lot of patients. But you can see on this list a lot of other conditions as well associated with elevated triglyceride levels. You also look at the kind of diet and lifestyle issues that are associated with elevated triglycerides. We really try, our first step is to look at those lifestyle changes to improve this. There are some medicines that are used in practice that are associated with elevated triglycerides. Truth be told, they're not usually the major reason, maybe with a couple of exceptions. Elevated triglycerides with prolonged propofol use in the ICU, we definitely see that. And the only other one that's on this list that I think is not uncommon to see is, which we don't really use anymore, are the protease inhibitors for HIV management. Again, those are really second-line agents in HIV now because of that. Okay, and then obesity, overweight, and poor glycemic control are all, and metabolic syndrome, all associated with elevated triglycerides. The first line therapy for most times when you're looking at drugs, drug therapy intervention, beyond those lifestyle things they'll talk about, are omega-3 fatty acids. And these guidelines steer you toward the prescription omega-3 products. As a pharmacist who sees lots of patients who have financial burdens to them, I will say that and what I see most clinicians do is first go with a highly reputable brand of a fish oil over the counter. So instead of hundreds of dollars, fish oil is going to be, $100 or more a month for a prescription omega-3 fatty acid. You're probably talking more in the range of $5 or $10 a month. So, the non-prescription fish oil, they are dietary supplements. They're not officially FDA approved for elevated triglycerides. Their content may vary and purity may vary, but if you're sticking to a therapy that is a reputable brand of a company that's USP approved, then those are often, most clinicians will look at the first step, particularly if the prescription omega-3 product is not covered by insurance. The tolerability about fishy taste, burping, and dyspepsia actually, after patients on one of a fish oil products for a while, is usually less of a problem after they've been on it for a couple of days. If that's a problem, particularly early on in therapy, some patients find it really helpful to keep their fish oil in the freezer of all places. And when they take their fish oil, they almost don't have any of the burping or fishy taste if they do that. And after you're on it for a couple of weeks, that potential often is more tolerated, and you don't have to keep them in the freezer forever. So the omega-3 fatty acids, they've been around for a long time. There's been correlation of high fish diets with high omega-3 fatty acid in them are associated with some cardiovascular benefit. The downside to these are maybe they can be associated with a bleed risk. And we sometimes, with any of these supplements, we might consider holding them in a high bleed risk surgery patient for a couple of days before surgery. So you'll sometimes see in surgical guidelines, depending on what it is, you'll see, prior to 5 days prior to starting, prior to coming to surgery, we want you to hold your aspirin. We want you to hold your non-steroidals. We want you to hold your fish oil. We want you to hold your garlic. Those are not uncommon to see that. There are a couple of prescription-only omega-3 fatty acids. One is Loveza. This has been around for a bit, and this is one of these options that we have, an alternative for elevated triglycerides. And the data here is about the same of what you see for fish oil, is 26 to 45% reduction. And the other one is Vasipa, which is also similarly effective and a consideration. In my mind, though, despite these guidelines recommending only using the prescription because it's less variable response, I think if you're looking at a USP fish oil product, that most clinicians would steer patients to start there, particularly if you're measuring triglyceride levels and looking for an improvement. Many of the remaining slides are algorithms that I encourage you to sort of walk through, but they pretty much will look at diet and exercise, evaluating their risks for their elevated triglycerides, looking at optimizing glycemic control, particularly in patients with diabetes, avoiding, high glycemic index foods that really seem to be correlated quite closely for many patients with elevated triglyceride levels. The foods that we're looking to avoid are added sugars, total fat, and alcohol. Alcohol is really quite problematic with elevated triglyceride levels for a lot of individuals. And also then increasing aerobic action and exercise with trying to get to some degree of weight loss as well. The lifestyle modifications here, you see reduction in triglycerides with weight loss up to 70%. Dietary modification, including alcohol restriction, again, up to 70%. Pretty dramatic improvements with exercise alone having improvement as well. So this is really where to start. So as you're screening patients with elevated triglycerides, here's a few questions to ask about, particularly their glycemic index in their diet, fatty foods, and alcohol intake, their weight, and their physical activity. And then looking at all of the kind of strategies, we talk about this throughout the year, is, setting goals with patients to set one goal. Maybe the first goal might be is to avoid sugary drinks. So try to cut your consumption of soda and or transition to a diet soda and ultimately to no soda, diet or otherwise. Try to limit alcohol intake, lose weight. But patients are going to have difficulty doing all of these things at once. Most patients would at least. So set goals appropriately. And then here's an algorithm for what to do with patients with atherosclerotic disease with elevated triglycerides and in this scenario, you're primarily looking at the LDL cholesterol management with the statin, and then layering on it, usually a first step, is one of the omega-3 fatty acids on board there. When you go on farther down, you look at different sort of cohorts in these algorithms. I'm again not going to go through them, but you're doing all the diet, exercise things, and then looking at, are they candidates for adding a omega-3 fatty acid. Beyond that, you're also looking at appropriate statin management and the atherosclerotic disease risk categories. So you're looking at statins, and then are they candidates for all the other non-statin options we had in LDL cholesterol management. And then you're looking at folks who just have elevated triglycerides alone. What are the other atherosclerotic risk factors that you're taking into account to consider if they're candidates for statins, for example? And then more data here. As you look through these, as you get farther down with elevated triglyceride levels, particularly over 1,000, but even below over 500, when you've exhausted everything else, you then might look at the fibric acid derivatives on top of the omega-3 fatty acids. Of the fibric acid derivatives, the one that had historically been used the most often is gemfibrozil or Lopit. This has been around for a long time. It's pretty effective at lowering triglycerides. So it's really an indication, usually pretty well tolerated. There might be a bit more risk with any of these fibric acid derivatives in conjunction with a statin, but most patients tolerate them pretty well, even in combination. Gemfibrozil can be associated with some GI upset in patients. There are some drug interactions that we are sort of careful about. The statin regimens with the myopathies are sort of less commonly observed these days with, for whatever reason, atorvastatin or rosuvastatin, but still might be an issue. And you want to keep in mind you're watching liver function pretty carefully as well. The other two fibric acid derivatives that are commonly used, well, really, the one of the two is fenofibrate or Tricor. Tricor is used probably, it's very similar and sort of adverse effect profile and efficacy. I see fenofibrate probably used more than gemfibrozil these days. I don't really see Atramid S used very much because of its potential cancer and cholelithiasis risks. So I don't see that one. But fenofibrate, you will see that not uncommonly in patients who have really elevated triglycerides. An older therapy that no one uses anymore, not in the guidelines, is niacin, high-dose niacin. It causes flushing. It's been associated with hepatotoxicity, reduced glucose tolerance, hyperuricemia. It's really an outdated therapy that people do not do anymore. And the dosage required for niacin is much, much, much higher than the dose that's in a multivitamin. So niacin's an old therapy that used to be used 2 decades ago, is really no longer an option for us. Let's look at some updates in late 2023. Again, from the same set of guidelines we are looking at and reviewing at the end of each of these cardiovascular blocks. Again, there's the strength of evidence and also the strength of the recommendation on the left-hand side. So one of the things they really reiterate is the importance in patients with chronic coronary disease to look at achieving a high degree of statin or high intensity statin therapy for everybody who's at risk for or significant risk for chronic coronary disease. And that's a strong recommendation. I think what you see reiterated over the last 5 years or so is the role of high intensity statins in every patient who is at reasonably high risk to achieve a reduction in major acute coronary events. And so to the extent that patients can tolerate it, we usually push statins to their maximally tolerated dose. If patients can't tolerate a maximal or a high intensity statin, they often may benefit from a moderate intensity statin, either choosing a different statin or choosing a statin at the same statin at a lower dose. In addition, they talk about follow-up lipid levels, fasting lipid levels 4 to 12 weeks after a start or a change in statin therapy and periodically monitoring it to just assure that patients are both adhering to therapy, but also that there's not something that's changed that should be modified. And then they have other sort of recommendations as well about the cost effectiveness of that and how we establish individuals who are at high risk. They further go on to review patients who are at very high risk, the roles of alternative therapies. And so Zetia is listed here. The PCSK9 monoclonal antibodies are here. And there's even some brief allusion to some of the other therapies in sections 10, 9 through 12, actually, about other therapies where they recommend that their impression is that omega-3 fatty acids, fenofibrate, dietary supplements, niacin, don't really offer a significant benefit for cardiovascular risk aversion. Now, particularly fenofibrate, I think, and omega-3 fatty acids may play a role in patients who have elevated triglycerides, which would pose a risk, among other things, for pancreatitis. But that's not listed in the chronic coronary disease management guidelines here because that's a different condition or a different disease state. They also reiterate how they define high risk and very high risk patients for future coronary events. They give a nice little synopsis, including where they stand on the evolution of data for non-statins and where they kind of fit in practice. The data that's evolved, there's more data for Zetia and the PCSK9 agents than there are for some of the newer agents, and they allude to that data is not really fully developed yet. We may see that expand or change over the next 4 or 5 years. I think, in fact, we should probably expect that to see that. They also list what reiterates the high, moderate, and low intensity statins, which is pretty much the same of what we've alluded to before. And then their algorithm looks at healthy lifestyle for everyone, and then the role of statin therapy, and then for very high risk patients beyond maximally tolerated statins, what's the sort of the next steps? In the last sections here, they make a interesting note, which I think is a low recommendation, but expect to see more on this. We know that colchicine is a pretty significant anti-inflammatory agent that has primarily been used for gout, for elevated uric acid level gout in particular. But as its agent that is anti-inflammatory, it may actually have some coronary benefits that we're not really sure of yet. So they make a very soft consideration about keeping our eye on whether colchicine may offer some benefit in the future for patients at risk, significant risk for coronary events. That said, I think most clinicians are intrigued by this finding, but wouldn't necessarily add colchicine therapy to patients who don't have another reason for colchicine. But again, keep your eye on this. It's a very interesting finding. Lastly, the data for use of drugs in pregnancy. And what I allude to here on the right-hand side is that the statin classes are no longer considered absolutely contraindicated in pregnancy. That is an evolution that's happened over the last couple of years. They're still considered risky, but they recognize that there's evolving new limited data that suggests it's probably best to be avoided. I think the answer is that if you have a woman of childbearing age who would be a candidate for a statin, particularly if she's pregnant, that might be an issue that you sort of raise with cardiology in conjunction maybe with OBGYN about assessing and quantifying that cardiovascular risk, and making sure that the woman is well informed that we really don't know what the statin risks are, that we used to consider them contraindicated in pregnancy. There's data to suggest that they might be in high risk patients, coronary risk patients, who could be or are pregnant, that statins the benefit may outweigh that risk. But again, keep your eye on that. That's an evolving scenario. And lastly, here's our list of drugs that, while we don't necessarily expect you are familiar with the doses of these drugs in this block for exam purposes, again, when you get to clinical practice, our expectation is you should recognize what are some of the common doses for many of these commonly used drugs.